Here we go. All right, welcome. If you're here, welcome. We'll get started in just a few seconds or a few minutes, three minutes to be exact. If you just joined us, please type in the chat that you're here. Okay. And I'm trying to get my chat up so I can see. Oh, you're a panelist, Latoya. That's why you can't do everyone, but you should still have it. No, just host and panelists.
It looks like Elizabeth Velasquez is a panelist as well.
Hi, Elizabeth.
Hello, how are you?
I'm good.
Can you hear me?
Yes, I can hear you.
Okay.
What hospital are you from?
I'm from Martin Luther King.
Well, welcome. We're going to get started in a few minutes. You have a panelist link, so I'm not sure you're not going to be able to answer questions, but if you want to, ask a question, please, just let me know.
Okay.
Okay. So you'll
Thank
only
you.
you'll only be chatting to us.
Okay, sounds good.
Okay. Good morning, everyone. Good morning, Yvonne. Welcome. Welcome. We're slowly getting everybody here. We will start at 11. One more minute. Welcome, Marie and Yvonne from Riverside County. Samantha, Tahoe Forest. Wow, we're filling up quick. I love it. Good morning, Robert, St. Jude. Rebecca Harris, I haven't seen you in a while. Nice. I'm so glad you're here. All right, guys, we're filling up. We're excited about this training today. It's really going back to the basics for screening tools and documentation. So for some of you, it'll be a review, but as always, our mentors are here to spice in and get this discussion going. So I'm excited because they've always got great stuff to say. Our mentors are the best. So I rely on them heavily. If you don't notice, they are the knowledge around here. So we'll wait. People are still. Hi, Dale from Temecula. So nice to see everybody. I feel like I haven't seen anybody in a long time. So which I have more to say on that because I'm going to see some people soon. We all are going to get together. So I'm really excited. All right. Good morning, Raphael. Hello. Okay. It's 11. I think people are still signing on. Joseph, Clovis. Boy, we're all over California today. So this is just great. Xenia at Stanford. Hello, Xenia. All right. And if I didn't say your name, it's just because the screen and the chat are going way too fast. I mean, couldn't keep up at the time. But I welcome everybody. Welcome to our Navigator focused series. We're talking about screening tools and documentation today. So let's get started. We share all of our information. It is copyrighted through Creative Commons. You can, we share it out. You just can't change it. So this is our copyright. These are our objectives today. There is a CEU, so we always are obligated to show our objectives for the CEU through KDAP. And these are our objectives. This is today's agenda. Welcome and announcements are now. We're going to be talking about all the different screening tools, patient intake tools, behavioral health, integrating motivational interviewing with screening tools. This has been a hot topic lately. Lots of navigators want to talk about motivational interviewing. So, and then we have strategies for documentation. We want to make sure everybody has a great experience today. So make sure, first of all, your computer computer is plugged in and it's not going to go dead, right? Close on any unnecessary windows. If you do have a question, we love questions. We love the chat. If we miss one, we will go through it and we will always answer it on Slack if we didn't answer it here. But make sure you address it to everyone. On the bottom of your screen in the chat, there's a 2. Just make sure it's everyone, because I'm sure if you have that question, everybody else wants to know. So please address it to
Hello.
everybody. Hello.
Can you hear me?
Yes, Tommy.
I don't know why I can't get this freaking,
Tommy, we're live. We are
Oh.
live. Okay, so the Bridge Navigator program, we want to remind you the deadline to apply has changed for the grant. So if your facility has not applied, the deadline is December 15th. So this is a change. So if your site has not applied for the last round of funding, this will be it, December 15th. If you do not know, please reach out to us. We will let you know, but this is very important, okay? So take note. If you have any questions, please let us know. And I was telling you about getting together. Well, we are going to be having our first BNP training, our Bridge Navigator program grant training. This is our first one, building and strengthening your Bridge Navigator program. It will be November 1st in Los Angeles. So I cannot wait until you guys, we can get together. And again, we're going to have one in Southern, and we're happy to announce one in Northern California. Oakland will be February 27th. So both of these, you can register. We dropped it in the chat, I believe, right? Yes, we have it in the chat. And if you have registered and have not received emails about the event information, please contact us, okay? Please. And yes, the deadline for the last grant funding is December of this year. Okay. December 15th of this year is the last grant round of funding. Okay. All right. California Bridge, we always put down our mission and our goal is to provide 24/7 access to high quality treatment of substance use disorders in all California hospitals by 2025. And we are well on our way. We're nearing 200. So this has just been such a great advancement and growth opportunity with California Bridge. And you're all here. So this is wonderful. I always like to just review what our California Bridge model is, because sometimes we get caught up in the weeds of things and we don't know our basics. And our bridge model is very simple, you guys. The three pillars: low barrier treatment. That is your physicians giving MAT and X-waiver prescriptions, right? That's low barrier treatment. You, my navigators, have the last 2 pillars: connection to care and community. You are talking with the patients and referring them to treatment or referring them to community partners, correct? And the last one is culture of harm reduction. You're changing it up in the emergency room. You're meeting patients where they're at. We've had some great navigator stories just about how the culture is changing just by simple acts of changing language, right? Or being nice to a patient that was termed a frequent flyer drug-seeking patient. So you guys are really the role models for this culture of harm reduction. So hats off to our navigators. You guys are doing an awesome job, and I'm so proud of you. And I love to hear the stories. And if you haven't shared, we're out there talking to everybody. And if you haven't shared, we will invite you to share. We have lots of events that we ask our navigators to come and share their successes and challenges. So we're going to start with the screening tools for SUD. And I just want you guys to type in the chat, are you using screening tools? Okay. Let us know in the chat if you are, yes, and which type you are. Kind of an informal poll. And I am going to bring our mentors, and I'm going to stop talking now and let some of our expert navigators, Chaya Vang and Tommy Trevino.
Hi, good morning, everyone. So there are many screening tools available, but today we are going to share some of the evidence-based screening tools and best practices. We'll go over audit, DAS, some pre-screening tools, S2B1 and B stat. So Tommy is actually going to go over the screening tools briefly with you guys.
Thank you, Chaya. So the SBIRT, we use the SBIRT, screening, brief intervention, referral to treatment, which we do automatically, even if we're not using this tool. I've learned over the years that, hey, we do it all the time, right? We screen our patient, give them a brief intervention. We're navigators. We figure out what their needs and where we can connect them to, and we refer them to that clinic, right? Or whatever program they need that's going to be best for them. So we automatically do that. And then the audit, I started using the audit when I first started being a son 7 years ago for alcohol. And what I learned from it was, after I did it 100 times, you kind of memorize this stuff, right? So like the first one, how often do you have a drink containing alcohol? And then I would ask the patient, and then I would get the number at the end, you add them up. And what I've learned was, I'd ask the patient if I'd share with them what I'm doing. And at the very end, we look up the number, and then down here, if it's like a 10, it would say like severe alcohol use or minor alcohol use. And most of the time, 99% of the time, I share with the patient, but wow, I didn't know that that's where I'm landing, right? So I thought this was pretty cool. I like this audit. It's really pretty accurate. Go ahead and move on to the DAS. And this is a standard drink. This is some of the stuff I would share with them, right? A beer, just because you drink one beer, it's not the same as a shot of whiskey or something. We'll go on to the DAS. And the DAS, this is used for, the audit was used for alcohol. The DAS is used for drugs, any kind of drug. So have you ever used any other drug other than required for medical reasons? Yes or no? The same thing. You would add up the numbers at the very end. You would look up the index, like right here, it says 1 to 2 low level. And come to find out, after, it's pretty accurate. I was really surprised. And the reason I started using these two is because I thought we were going to charge Medi-Cal for it. And these are some of the ones that Medi-Cal that you can charge, but it ended up being more hassle than what it was worth to try to charge. But these are two real good, accurate tools to use. And here again is the alcohol, what one drink is, right? One beer is 12 ounces, one liquor, just 1.5 ounces. So this is kind of educating the patient at the very end. It's like, it's not, instead of drinking 5 bottles of wine, man, when we cut it back to 2.5 a day, right? Harm reduction. Thank you so much, Chaya.
Screening to brief intervention, this is used for adolescents, 12 to 17-year-old. And it's just a question, have you used any substances in the past 12 months? Basically once, never once, or monthly. And that gives us a risk, we can use to screen the adolescent. The next slide. And then BSTAT is a brief screening tool that basically asks more for adolescents too, the same questions. Did you use any substances? So these are just different, like I said, different methods, different tools to use that to help screen your patients to see how high the risk of use is. Next slide. So how do we use these tools in person, like in real life? So we use it for my site for documentation purposes. So later on we'll share that in notes. If I used an audit on a patient, I would type in that we did an audit screening, and we'll share the score and what the action plan is with the patient. And then we also use it for referring purposes. The patient scored this much, and we are going to refer the patient based off of the patient's choice. Tommy?
Yeah, I found what I liked about the audit and the DAS was, if you have a patient that you've seen like a year later, and you can bring the audit back up, right? And maybe the first time you seen them was like, oh, you're moderate, right? And now a year later, you see them, you do the audit again, you go, wow, look what was last year. Your drink is getting heavier. You're back in the ER. Now we're having other issues, right? So you kind of use this tool, and it's good to keep record of it, of course, like we always do. And you can definitely you have to create a different plan, right? If it's more severe, the alcohol come in, your plan's going to change, and your referral's probably going to change. So it all depends. There's some patients that you work with that I've worked with for years, and there's other ones that I haven't seen again. So very good tools to use. Action planning.
Excellent, you guys. Like I told you, they always have the answers. And so how do you guys use these tools? You know, type it in the chat. I want to know, how are you guys using these tools? We have to do some type of screening, right? There's always got to be some initial, what have you done in the 12 months? And that's expert, basically, you know, because like Chaya said she uses it for documentation. Tommy uses it for action planning. Absolutely. We need to know how much, how often, and, you know, all of those things. And then for referral purposes, what's best for this patient, right? So Emerson says they use the tools to determine a patient's readiness and our willingness to go into treatment. Yes. Rebecca has a question. Do you save the audit and put it in their records to put in their chart and just document it and shred it? I would say save it and document it because it is patient related. So anything that's patient related should be saved to the record. Okay. Marie uses the ASAM for screening, developing an action plan. That's a big hefty intake document. I use these tools to see where the patient is as far as the stages of change. Also, we need this info for continuum of care. Absolutely. You know, it's the beginning of your interview, right? This is how we get started, and let them know what it is that you can do and the choices that they have for the type of screening that you did, and if they're low risk, moderate risk, or high risk. So that's how all of these tools are being used. I'm going to ask someone to put it in the chat. All of these tools mentioned today are on, I found this wonderful website. It has all of these tools listed in one place, so you don't have to go to multiple places. On our website, we do have the audit and DAS, but on the other Oregon's expert site, they have all of the tools. So it's up to you. We like to give choices, right? Definitely. So the ACM is used by us directly placed into treatment for the hospital. We created no delay in services because we transport to treatment with that ASAM. Okay, that's a different approach. Most hospitals do not do the ASAM in the emergency room as we do not have time. It's the brief intervention. So hats off to your facility for initiating that. That's wonderful. We have the DAS and audit and CAGE. Haven't heard of CAGE. I make room for change. I make sure to keep in mind that many patients misrepresent their usage. Very good point. Excellent point, Kelly. Yes, definitely. Okay, Camilla says it's built into our tab in Epic. That's really useful then, very easy. As he mentioned something earlier, we really promote not going into a room with computer or paper and just having a conversation, right? Because that's can be a barrier when they see another person asking questions. So definitely great. There's a lot of useful information here in the chat for you guys. Again, you got so much in the chat. We have the expert in Cerner. That's excellent. Yeah, a lot of the electronic record can have that. So great. Thank you so much, you guys, so much for all of your input. Next, we're really quickly going to go over behavioral health. So I talked about this last month, and the reason why I wanted to show you these commonly used tools is it can help you when you're looking through the patient chart and you see the CSSRS or the safety, you know what they mean, and that they're something to evaluate suicide severity and evaluate a 5-step evaluation for the nursing department. So you can kind of know this is an example of what the nurses are asking. And this generally is usually a nurse asking the CSSRS. So I just wanted to remind you that there are screening tools for other specialties, but this one would be very important if you have somebody with dual diagnosis for you to review. We had our behavioral health navigator focus series last month, and it is on our training videos. So if that's something you want to review. So I just wanted to review quickly. I'm going to hand it over to our mentor, Latoya. She's going to talk about the patient intake tool, which is a really great resource. She's going to tell you all about it. Go ahead.
Absolutely. Okay, so quick question. You can go ahead and type in the chat before I move on to the next slide. But let me know if you use this intake form or any version of the intake form. Next slide, please. Okay, so this intake form is on the CA Bridge website. It was developed by all of you, probably, or many of you know Christian, who did a lot for the program. But it was developed by Christian and other mentors and navigators. But although there's a lot of information here on this intake form, I really want to highlight some main points on it. And I've outlined them here in green for you. And the reason I highlighted that section is because it's an aid to referring the patient to treatment options that they choose. So I call it kind of hitting the hot spots, especially if time is a little bit limited. You want to get those hot spots and really focus in on that, on those key details that are going to help you refer the patient to ongoing treatment. So certain things like, what's a suitable harm reduction plan for them, whatever it is, whatever treatment option that they're using. And then, let's see. Trying to see this a little bit small. Other information that's on here you might be able to get later on or fill in yourself later on, like name, reason why they're there, any of the other demographics. You don't have to fill out right then and there. You can, do it either before you see the patient or even after you see the patient, just for saving time's sake, and again, just to modify the intake form. Next slide, please. So this one I've highlighted a couple of different areas in different colors. So again, the green is going to really help you narrow down those significant areas to refer to treatment. The orange is going to be, again, for the harm reduction portion. So, knowing the route of use and if they have history of overdoses and things like that, then if you're going to give them a list of syringe exchange services in the area, you're going to give them Narcan to make sure to chart that, things like that. And then that pink section is geared more towards mental health and other medical history. Things also like overlap in care, such as Hep C treatment. Do they need to get tested for HIV, syphilis, hepatitis C, things like that? Do they need, again, access to sterile syringes and those sorts of things? So you can go with some of those highlighted portions of the intake form, modify to what works best for you and your workflow and what works best for the patient. Some of the reasons why you might modify a tool would be to save time. It really does improve the patient flow. A lot of times you have other people in place who are doing screening, such as nurses and the healthcare team. They might already be doing their own version of screening. And then there might not be other tools in place, especially if you're not part of the case management or social work department of the hospital. And this is something completely brand new to the whole healthcare system that you're working in. You might need to develop some sort of tool to start off with and really get your groove of doing these in-person intakes with the patient. So this is a really good resource to use, and again, modify to what works best for you, the patient, and the workflow of your hospital. That's it.
Thanks, Latoya. Thank you very much. I hope that was helpful, and our intake tool is on our website. We will provide that link for you. So if you haven't found it, we're here, we're helpful. We're going to give that to you and modify it. Like Latoya said, this is not a one size fits all, but it is a guide for you. You can make your own. You could do whatever you want to add questions. So don't feel it's a one size fits all. And it is a very helpful tool. It will guide you to what you need. Some of it, the information can be found if you kind of want to look around the chart and fill it out. So that way you're not asking the same questions or you want to confirm. So again, it is in the chat. Next, we have our mentor, Marianne Gold. She's going to talk about motivational interviewing. How are you going to get all of this information? And how I hear this a lot, and our navigators are such the greatest role models. How did that patient tell you that? How did you get them to tell you this stuff, right? Our navigators are a prime example of how motivational interviewing works. So Marianne, to you.
Thank you, Sherry. Yeah, we started talking about utilizing motivational interviewing when at a few of my sites, we had several patients in a row saying no, and sons feeling somewhat of a loss in terms of finding an opening or creating ways to be able to spend more time with patients and also have them share more with them. One of the things that I love about utilizing motivational interviewing in our work as sons is that we have the advantage where clinicians don't often have the time to take with patients. We can take time as sons to explore ideas and talk with them in a non-clinical way to what I like to consider create openings in the conversation, finding pathways to offer options and also explore where the patient is, where with clinicians, the approach sometimes can be so direct that our patients often shut down and aren't willing to explore even any option for treatment. So just to kind of go through some of the fundamentals of motivational interviewing, some of you may have already had motivational interviewing training, and this might be new to some of you. So these are kind of just the nuts and bolts. And if you have an opportunity to do a motivational interviewing training, I highly recommend it. So motivational interviewing is a technique for building rapport and trust with the patient. We know that this is key to working with our patient population. We're motivating patients towards change, right? We want to help them to identify where and what it is that they can change. We don't want to tell them what to change. We want them to identify what changes they can make right now. We're creating a partnership and finding acceptance and compassion with where the patient is right now, right? Not where they can be, where they have been. We really want to create this opening in the moment that we have with them. We're asking open-ended questions, and we are creating affirmations with the patients. We're giving reflections and summarizing what they have shared with us in that conversation. Motivational interviewing is not confrontational. The sons that I work with at my 3 sites, we have this sort of ongoing joke that we are not the recovery police, right? Oftentimes, clinicians or nurses will come to us and say, well, didn't you tell them that they're going to die if they keep using, or they have to go to treatment? And we will remind them that we, in our roles as substance use navigators, we are supportive, we are building trust, we are creating rapport, but we are not telling our patients what is wrong with them and what they need to do. We all know that without their without their willingness, nothing can happen. Next slide, please. So I'd love to hear from you in the chat as I go through this slide. What do you do when you come up against behavior that suggests unwillingness to engage or just resistance model behavior? What you might see is anger, irritation, or aggression, even when you enter the room. Defensiveness when you start talking about substance use, denial, withdrawn. I've had patients just close their eyes and kind of refuse to talk with me. Avoidance, they may not answer direct questions. They might ask for food or for water. So I'd love to hear from some of you in this audience what it is that you encounter when you're experiencing resistance. If you are experiencing resistance, you want to change the direction and develop more rapport. A lot of times I won't even talk about substance use. I will just talk about, I'll ask people where they live. I'll ask them if they have, family or friends, or even talk about their pets, anything that they're willing to share with me. I will use that as an opening to explore more. So change talk. Things a patient says that lean towards positive change. And this is where these are leading conversations. I don't always feel good when I use. That's a great way to explore, ways that they do feel good. I have stopped using in the past. I can stop if I want to. Ask open-ended questions about what they did. How did it work for you? I really care about my son or daughter and want a better life for him or her. What would that life look like? What is one small step that they could do today to get closer to having a life for their child? I can't believe this is happening again. So really fostering some empathy in those kinds of statements so that the patient really knows that you are in that experience with them and that they can trust you, that you understand how painful this is for them, and that deep shame that comes with addiction, they're sharing that with you. So really encouraging this thinking and start moving the patient towards an action plan. And it could be very simple. It doesn't have to be, a 5-year plan. It could just be what they're going to do when they leave the hospital by offering them all of the options. I'm just trying to take a moment with some of the chat to see. I try to re-gear the conversation in a positive direction and flip the script in a positive way. Use those challenges as opportunities to make it positive. Exactly. I love it. This is not what our patients are expecting, right? When they come into the hospital, they aren't expecting this positive lens towards anything that they're doing. So that's really powerful to offer them. Yeah, so Kelly Ramirez says, sometimes I ask if I can sit at the edge of their bed. I think our body language as substance use navigators is really crucial in terms of how we enter the room and the way that we're spending time with patients. I often try to just sit down and then have my hands in my lap so that I'm not holding anything. My phone is put away. I don't have a clipboard, and I'm just really creating presence. So we're going to do a little role playing. Again, I love all this participation. I think that this is a really big part of the work that we're doing as far as sharing with each other, because as you know, each time we enter a room, the experience is going to be different, right? There's no formula necessarily. We have all these tools, but every person that we work with invites us to utilize everything that's available to us in order to really engage and offer resources and support this person. So LaToya and I are going to do the first case study. These came out of real patients that we've worked with. So case study 1 is PP, or we could say Penelope Peterson. And Penelope is a patient that struggles with substance use disorder. She doesn't acknowledge having a problem, and she's declining services. So LaToya and I are going to just kind of explore this together with some motivational interviewing techniques. And then I'd love to open it up to some suggestions of how we could have done this differently. So, hi, Penelope. How are you doing today?
I just, I don't even know why I have to talk with you right now. I have this abscess on my leg that I came in with, and that's the only thing I need fixed right now.
Yeah, I can understand that, Penelope. So are you feeling like you just want to see the doctor this morning?
Yeah, I mean, if that's what's gonna fix this lump on my leg.
Well, I wanted to come in and say hi. I had seen you, is it 2 weeks ago? And I just wanted to kind of check in and see how you were doing, see what was going on.
Well, I mean, I'm here again, so that should tell you.
Well, where have you been staying, Penelope?
Lately I've been couch surfing and just staying with friends here and there.
I'm really glad that you came in.
I think last time you said if I came back that you could help me get some more tools.
Absolutely. Yeah, I'm glad that you brought that up. What kind of tools do you feel like would be helpful for you right now?
Well, I think when I'm when I muscle, that's what's making the abscesses. So I need some clean needles.
Great. Yeah. Are you familiar with harm reduction services in this town?
No.
So I'm going to give you an address when you leave here, and it's actually just 5 blocks away, and you can walk in and get clean needles.
Oh, wow. Okay. Is it free?
It is free, actually.
Okay.
Yeah.
That'll help a lot. Thank you, Marianne.
I'm really glad that you're asking for some safer use options too. I think that that's a really positive step towards taking care of yourself.
I wouldn't have felt comfortable asking if you hadn't have mentioned it the last time I saw you a couple weeks ago, but since you told me, I wanted to just see if you were for reals about what you said.
Yeah. I was thinking about some other ideas also. Are you feeling open at all to talking with anyone or seeing a counselor or getting some other support?
Maybe not yet.
Okay. Well, I'm going to get that address for you, and I want to give you my card in case you change your mind, and know that you can call me anytime.
Okay. I'll take your number, and don't be surprised if I hit you up.
Look forward to it.
Oh, that was awesome, you guys. That was really, really good. I loved it. I had to say something because this is what you guys are doing every single day. And it's meeting where she was at. She's not willing to divulge. She's not ready for our screening tools or anything. It's just one simple step. I was told in the chat that somebody has a question. Tanya, did you have something related to what we're doing right now? Did you want to unmute?
No, I
thought you
didn't.
had.
Sorry, I didn't have my hand up.
Oh, okay. Just wanted to
Sorry,
check.
but hi,
No.
it's nice to talk to you.
It is. It's nice to see you
Yeah.
guys. Want to make
Yeah.
sure. I was like, what?
Yeah, I really appreciate these trainings. Thank you.
Awesome. Thank you for being here.
Oops, Sherry, you're muted, but I do see you
Okay.
talking.
Go ahead. Do you want to go on?
Okay, yeah, wonderful. And I wanted to say just one last piece about our Penelope Peterson role play, which is that it is enough. It's enough to meet people where they are. I think oftentimes we can feel like we need to create a solution in that moment, or we need to solve all of the problems that our patients come in with. And it is absolutely enough to just respond to their immediate needs and to offer them the resources that they're interested in. And that's really meeting people where they are. And so you should all feel really good about being able to do that. Okay, so our case study 2 is Mary Jane, and Mary Jane has a history of co-occurring disorder of alcohol use disorder, anorexia and bulimia, and personality disorder. The Navigator has worked with this patient for about 4 years. And the Navigator has exhausted resources trying to get the patient into treatment that will fix her complex needs. So Chaya and I are going to explore this. And many of you have had these patients who are dual diagnosis. And, you know, one of the big barriers I know that we encounter with our patients is that the payer or their insurance just doesn't cover dual diagnosis treatment. And so it's very challenging to help to find support and resources and then to stabilize people during outpatient. So Chaya.
I'm ready whenever you are.
Okay, great. Mary Jane, it's nice to see you. How are you doing?
Hi, I'm okay. I don't
Well,
know
tell-
what. I'm here again. Sorry.
Yeah, I see that. You don't have to be sorry. What brought you in this morning?
I don't know. I was at a treatment place and they kicked me out.
Yeah, I know you've been having such a hard time. I'm so sorry.
Yeah. I really need a place to stay, Marianne.
You know, we are working to try to find a better option for you. And I know that it's been really challenging to find some stability when you leave treatment. Have you called your counselor, or have you seen your doctor since you've been back from treatment this time?
No, I don't want to.
Why don't you want to see them?
Well, I just feel like I failed, so I don't want to call them.
Mm-hmm. I know it can feel hard to be disappointed in yourself, but each time that you go to treatment and when you come home, it's okay. It's okay to just know that you're doing enough. Do you like your doctor?
Yeah, she's okay.
You feel comfortable talking with her about what your needs are and your concerns?
Yeah, she gave me some meds, but like, I don't know if it's helped me or not, or am I taking it correctly? I don't know.
Are you taking your meds?
I am. I don't know if I'm taking it correctly.
And how much are you drinking right now, Mary Jane?
Probably like 2-3 cans a day. I don't know.
Well, I know at the clinic, there is the counselor, the substance use counselor, and she does have an opening. You could see her once a week and get some support around the alcohol piece.
How soon?
Are you open to that?
Yeah, how soon can you get me in?
Well, let me give her a call. I'll step out and I'll give her a call and we'll see what kind of availability she has this week.
Okay. Thank you so much, Maria.
Okay. You're doing a great job of coming in.
Oh, thank you.
Another great scenario, you guys. I hats off to our mentors for role playing, because this is something, I mean, these are our patients, right? We know these people. These are people that are coming into our emergency room. And I love the way Marianne and our mentors, our mentors are resistant to Marianne, and she's got to really use that positive, open-ended question. She's got to give that affirmation. And she was doing all of those motivational interviewing. If you've seen that and followed her, she was giving affirmations of what a good job they were doing coming in. She was summarizing, she was reflecting on what's going on in their lives. And it is just a really, that's why we do these role playings, is so that you could see this in action, and that she was actively listening is what Matt Paul, yes, paraphrasing what they're doing, and just explaining, let me see, did I get this right? This is what I think you meant, making sure that you're not speaking for them. She didn't speak for them at all, right? She just reaffirmed and reflected on what they were saying. So excellent job, you guys. Hats off to you. And again, sometimes we can just listen, say, I'm here, even if they're not going to talk, or maybe can I come back later? And sometimes they'll be like, I want lunch, I want this, right before you leave the door. So, you can kind of throw that in there. Well, I'm going to get you this, I'm going to let you eat, and then I'll come back. And you better come back, right, Marianne? When you say you're going to do something, your patient is expecting, even if they're not ready or they're not answering their phone, they're looking to see if you called, right, Marianne?
Yep.
Thank you so much, you
Thank you.
guys. All right. Our last topic is documentation for navigators. And we always like to review, because I know a lot of you have questions. And when should a navigator chart? These are some of the reasons. Any encounter that you meet with the patient or their family members, right? Anytime you're doing that, any interaction with the patient or family. If you're referring, you want to chart something, right? Where you're referring them, whether it's to a treatment center, whether it's you referred them back to the doctor. They may have asked questions that you cannot answer. Referred to their nurse, referred to their doctor. Sometimes you have to refer to social services, correct? So always make sure that you're telling a story. What is it? Does the son need to chart? Well, for one, I always give the advice, always write patient states. That's probably the best advice I can give to you, because if they say something that's meaningful, jog it down. That's like a gift if they're saying this stuff that's written on here, right? If they don't feel good, if I feel like shit, my wife kicked me out, use their words. Don't try to change their words. Their words are what their words are. And sometimes, you've got to type that to reflect the situation that you're in. So do not change their words of what they said. Correct quote, patient says, I don't give a bleep. Okay. Type it out, because that relays the time and what is going on at that minute. It might be an hour later, patient apologizes to me, says, I was in a really bad place earlier. Please forgive me. Those are really great gifts to chart. What you do not want to chart is your opinion. Okay. We cannot give our opinion on the record. Okay, you might go to the nurse and just say, hey, I don't feel this patient should be here. I feel this patient should be on boot. That's not your scope to give your opinion, or it is your choice to give it your opinion to the nurses and doctors, but not to put it in the chart. Okay, there's a difference, because number one, if that chart ever went to any type of legal counsel, they're going to ask you your scope and your role. Okay, so you don't want to have to defend that, you guys. You want to say, I referred to the doctor, and that's all you need to put. Remember on the previous slide, okay? So you don't want to put, I argued with nursing and doctor because they wouldn't listen to me and the patient, correct? A better way to say it is the patient was given an option, does not agree with the treatment plan, okay? You always want to be the advocate for the patient. It's not personal. It's not upon you. It's patient. It does not agree with the treatment plan, does not agree with the options. Explain to patient, he does not have to agree, right? So just want to clear that up of what not to chart. But what you're not charting is I went to my supervisor and she told me I could not give money to the patient, period. That's a conversation that you need to have with your supervisor and take it on the chain of command where you're working at. Okay. So again, if you have any questions about charting, please let me know, because we do not want to steer you into a wrong rabbit hole, right? And then abbreviations, although you may know some abbreviations, okay, by the way, BTW, right? And if you're younger, the younger generation has so many abbreviations, I have no clue. But if they are not medically acceptable, they do not live in the chart, okay? Because again, it has to be legally and medically accepted. Nobody knows what you're talking about if it's not a legal medical abbreviation. So even though you might think and all your friends are using it, again, it has to be a well-known medically accepted abbreviation. Okay. Any questions, you guys, on charting? Okay. And then there's a time just for a narrative note. And that's what we've kind of been going over, because some people have templates and some people don't. There's several different types. You can do a DAR, you could use SOAP. Just remember, always be objective, give real-time actions, okay? What you're doing right now, okay? Quote the patient, document any encounter. And remember, if you didn't chart it, it never happened. So if you're not charting something that you saw the patient at the bedside, guess what? You never did it. Doesn't matter if you remembered and it was on your phone. And that's why it's always important. Real-time action. Sat with the patient at bedside for 25 minutes to discuss treatment options. Okay. Make sure it's correct, accurate, and objective, not your opinion. Okay, so here's just an example, and then I'm going to hand it to our mentors to give us examples. So data, this is a DAR, data. I have not used opioids for 8 hours and I'm starting to have withdrawals. Action, I sat at with the patient at bedside, discussed MAT with buprenorphine for 20 minutes, okay? Response, patient says, I will accept naloxone harm reduction kit and will call son in 3 days, okay? Didn't give opinions of why they didn't. It's just very precise of what has happened. Data, action, response. There's lots of several different charting types. The other is SOAP, which is subjective, objective, assess what happened, and then the plan, patient to be sent or to be given harm reduction. You could have used the same thing. So those are some techniques for charting. So I wanted to ask Latoya, how do you integrate your Navigator notes? What do you do for your charting?
So as a substance use counselor, I actually used to use SOAP more frequently. But as a navigator, realizing that on the back end, so many other people have access to these notes and all of the charting, I started, I started keeping it short and sweet. So I put that I went over confidentiality with the patient, that they signed the confidentiality, that I gave them a summary of their rights. I will put that they were referred to treatment, what the treatment center was, that they were provided Narcan and educated on how to use it. And then I will put whether or not they were given a prescription and for how long. So mine are very short and sweet. I don't put any of the other details in there. But that's just so that I could help the stigma reduction and any potential harms to the patient by other people accessing their information.
Great, excellent, Latoya. Chaya, I'm gonna stop sharing my screen. Chaya, do you want to give an example of how you do your Navigator notes?
Yeah, let me share my screen.
Okay, go ahead. And while we're waiting for Chaya, how are you integrating your notes into the patient record? Type it in the chat if you have any best practices for our navigators.
So for me, I've been very fortunate. I use Epic. So when I moved to case management, they built a tab for me. And all this is I just click through it and it becomes a note. So this is what just the note looks like, the template of a note. Identified drug use, all this stuff is filled in for me already. And if I do an assessment on them, depending on the drug of choice, the assessment will pop up with the this total, and we just go. And then I will briefly describe it in the intervention right here. So this is the only part that I actually have to type in. It's very brief, and like Sherry said, it's just facts, nothing of my opinion. This is what happened. Patient said this, patient is interested in treatment, and this is what we did, a referral. And I always put that somebody else is aware, that's the bedside RN, the medical provider, or even case management, somebody else knows this plan too. So they can back me up. And then this just goes on. And then at the end, right here, was the patient treated with buprenorphine, that it's automatic pre-filled. Narcan given, yes or no. Patient consent to follow up, yes or no. And I just put a phone number. The plan for treatment is either outpatient, inpatient, or whatever this patient chooses. And then I also provide the appointment date in the note, just so providers can see that. And it's also in the patient's discharge, so the patient can get it in a few places. That's it. And has my number at the end, so doctors can call me if they have questions or whatnot. So this is what my note looks like.
That's great, Shaya. I know some people are asking to get a copy of that sample. Do you know if where they can find that copy?
Yes, there is not the exact copy, but a very similar template on the Bridge website. I will find it and I'll link it real quick. I actually copied this template from Tommy from 3 years ago when I started. So still the same thing I use up to this day. But yes, I will find it and I will share it, guys.
Hey, Tommy, you were referred to. Did you start this wonderful charting note?
Yeah, I was gonna say, that looks a lot like mine, Chaya's. I mean, mine's a little different now. We're always changing it and adding, like, for instance, if the hospital wants, or anybody like my boss or wants certain information, we can add it in the dot phrase, like how many patients did we start on buprenorphine? We can pull that data. The patient smokes, yes or no, just click it. Everything's clicked. And I have a plan of action. Mine isn't an assessment anymore. Like Latoya said, I just write down, we just type in what we did. The social workers and case managers and doctors, they wrote all the other stuff. I mean, patient is the 26-year-old, assessment like they teach you when you go get certified. We just write a plan of action. It's like, patient was started on buprenorphine, 2-week script, connected one community health, we'll follow up in 5 days. Boom. Now we're established, the doctors trust us, everybody knows what we do, and they know that we're gonna follow up in 5 days. And we just don't put all that other information. I've learned that if the more you put in there, the more you leave yourself open to things coming back at you, right? And so I've learned just to put what we have to in there and just let it be done. We can be done with a note in 5 minutes. I mean,
Absolutely. Tommy, I do have a question for you. How did you get this into your Epic? Who did you have to ask? How did you start this?
I started with working with IT. We started with the dot phrase. I heard somebody say dot phrase. And then now I have Connor who works with IT. And I have permission. We have permission from the hospital. I connect anybody with Connor, and Connor would send over the dot phrase over to their IT, any hospital that wants it, so I can share it. I've been sharing it a lot. And then you can, from there, you can just change it, add whatever you want in there, whatever data you want to collect, put it in there. And then whenever you need something, I just ask Connor, I need this, and he'll pull it up for me if I go to a meeting. How many patients we've seen in the last month? 3 years yesterday. How many people we started on buprenorphine? How many people are homeless? You know, how many people smoke? Well, whatever data I want.
That's awesome. So again, just to recap, you can get the template. Chaya just put the link in there from California Bridge with epic dot phrases and reach out to your IT. Those are your homework things. If you haven't done that yet, find out who you need to talk to in IT to get these templates. Definitely. There is a question. Can you explain how to retrieve info stats? You know what? I think we are going to have a data Navigator update info, LaToya, soon coming up.
Yes,
And
next week.
if Gerald could save that question for our data guru, when is that coming up?
It is next week. It will be Wednesday, October 26th at 11 a.m. It is only offered on Slack. So we will post the Zoom link to the All Sons Slack channel.
Perfect. And I'm going to invite Tommy to come to that to follow up with that question about how to retrieve the info and the data from Epic and to get those stats. We are running out of time, you guys. I know it goes by so quickly, and I know there's plenty of questions. Remember, we're always on Slack and we can continue these conversations. I just want to say there is our resources. You can join us to learn more of our trainings, and we are always on our website, Facebook, Twitter, and Instagram. Here is our mentor team that you can reach out to. You can always reach out mentors at cabridge.org. I am Sherry Cisneros, and I am so happy that you were able to join us. We hope this has been very informative. As I said, our mentors are always filled with so much knowledge, and we will send out the evaluation via email. And have a great day, guys. Thanks for joining us today. Bye-bye.